Ready? Okay, how's this block so far? 1 second, eh?
نور فيك.
Okay, so today I guess Dr. Hassan Sheba started with he gave you a lecture on
Oral cavity.
oral cavity. Okay, so we'll continue. Today we'll talk about the esophagus, the upper GI, esophagus, stomach a little bit, and also the small intestine, just the beginning of that. Now, what is this? What do we call this section? Huh? Mid-sagittal section divides the body into two halves, right? Right and left. If we divide it anterior and posterior, what do we call that? Corona. So this is the sagittal section. What is this?
The nasal cavity.
What is that?
Trachea.
Huh? هذا what is this?
The nose cavity.
Nasal cavity.
This is the nasal septum. What is this?
Hard palate.
Hard palate. What is that?
Soft palate.
What is this? Uvula. Why do we need a uvula?
To the sound.
Yes. Yes.
To prevent food from going.
To the nasal cavity.
This is the uvula, right?
Yeah.
So it will prevent food from going
To the nasal cavity.
to the nasal cavity. So this is the nasopharynx. And this is, what is that in the nasopharynx? Huh? Auditory tube or the Eustachian canal. Why do you need an Eustachian canal?
Balance the air pressure.
Balances the air pressure, the pressure on both sides of the eardrum, the tympanic membrane. Okay, so that's why when you travel, you have high pressure on the eardrum. What do you do? Okay. What do you do?
Open your mouth.
Huh? You open your mouth. You yawn or you chew gum so that you equalize the pressure on the tympanic membrane from the inside and the outside. Okay, so that is the nasopharynx. This is the oral cavity. This is, what is that? Tongue. So that would be the oropharynx. Okay? Now what is this? What is the epiglottis?
Separating
the airway.
hyaline cavity.
What is it?
It's a hyaline
It's
cavity.
a hyaline cartilage.
It's a cartilage, right?
Yeah, that works like a bridge.
Okay, and it is attached to the base of
The tongue.
the tongue. And what is that?
Larynx.
This one. This one.
Larynx.
This is the Adam's apple. This is the thyroid cartilage, right? And thyroid cartilage, it has just only anterior plate like that. It's not a complete cartilage similar to this one. This is called the cricoid cartilage. It's like a ring. So when you do sagittal section, you will have anterior piece and posterior piece. So that is the cricoid cartilage. And that is the vocal cord. So now as you see, the epiglottis is attached to the base of the tongue. Why is this?
Because when you swallow, the
Epiglottis, you need it to prevent
food from entering the lung.
food from entering.
airway.
So when you chew, then you swallow. When you swallow, your tongue will push the epiglottis, will seal the larynx. Larynx will lead to the
The lung. Trachea.
trachea.
Trachea. بعدين
Trachea will divide into two main bronchi, one to each lung. Okay, so when you swallow, the epiglottis will seal that Laryngeal muscles will contract, will bring the larynx up. If the glottis goes down, it will seal the larynx, so food does not go inside the trachea and from the trachea into the lungs. Instead, food should go here. What is that? That is the esophagus. What is the esophagus?
The GI pathway.
What is it?
To the stomach. Tube. A tube. A pathway.
Tube made of what? Plastic, bones, cartilage,
Muscle.
It is a muscular tube. That's why when you go to the lab, you're not going to see a tube, right? And it's always
You don't see it inside
Close.
cadavers, right?
you will see it. You will see it. But it's not like a tube. You will see an open tube. You know, you can barely see this space because normally the esophagus is closed unless there is a bolus of food going down, then you will have peristalsis to push it down. Okay, so that is the esophagus. Here, so this is the pharynx. Esophagus starts at here, lower border of the cricoid cartilage. Okay, which is at the level of C6. Do you know what we mean by C6, T1, L1, L5?
Vertebral level. The vertebral.
You have the vertebral column, and we have the vertebra. We have 7 shabab. We have 7 cervical vertebra. We have 12 thoracic vertebra. We have 5 lumbar, 5 sacral, and 4 coccygeal, a total of 33 vertebra. So when it comes to levels, clinically speaking, you know, and from now on in anatomy we're going to say it is at the level of T1, meaning at the level of the first thoracic vertebra. It's at the level of L4, meaning it's at the level of
Fourth lumbar
vertebra. Okay? So esophagus starts at the level of C6, just below the cricoid cartilage. Esophagus is a muscular tube, okay, and it has 3 parts. One in the neck. It goes all the way from the neck to the abdomen, where it joins the stomach. Right, so it has a cervical part in the neck, and then it has a thoracic part in the thoracic cavity, and there is a small portion of it that is in the abdomen where it joins the stomach. Now the cervical part is here, where it is located behind the trachea. Okay, so that is the trachea. This is the esophagus. Sandwiched between the two, we have 2 important nerves. We call them recurrent laryngeal nerves. Recurrent, why? Because they recur. You know, they come from the vagus, left vagus, right vagus, and then after they descend, they remember, I have to go back and supply the larynx, or the muscles of the larynx. So that's why we call them recurrent, because they recur, go back. Laryngeal, because they supply the larynx. So we have one on the left, just below the arch of the aorta, and we have one on the right that is a bit smarter, we'll remember earlier, just below the subclavian artery, and they will be sandwiched between the esophagus and the trachea. Okay, recurrent laryngeal nerves, they are branches of the vagus and they will supply the larynx. So that is the cervical part, and then the esophagus, still behind the trachea, will enter into the thoracic cavity, will enter into the thorax. And when you read about it in the textbook, it says it runs in the mediastinum. What do we mean by mediastinum? Mediastinum is everything in the thoracic cavity minus the 2 lungs. Okay, so if we remove the lungs, everything in between is called the mediastinum. Okay, so the esophagus will be running behind the trachea. Trachea will end here. It will bifurcate, will divide into right main bronchus and left main bronchus to go to each lung. And then what do you think will be anterior to the esophagus here? Will be the heart, right? The heart, which is surrounded by a serous membrane called the pericardium. Okay, so below the bifurcation of the trachea we'll have the heart. Okay, now as you see, this is the left vagus, one of the cranial nerves. It's the main source of parasympathetic fibers. You know, we have left vagus, we have right vagus. They accompany the esophagus and they break up into plexuses of nerves, as you can see here. And then before it enters the diaphragm, they will form individual nerves again. They will go with the esophagus through the diaphragm to the abdomen. Okay, and then what is that?
Diaphragm.
Diaphragm, right? Diaphragm separates between the thoracic cavity and the abdominal cavity. So, but we have structures that will pass from the thorax to the abdomen or from the abdomen to the thorax. So you have to have what? Openings for these major structures. One of them is the inferior vena cava.
Descending aorta.
Second one is the esophagus. And the third one is the abdominal aorta. And the level, you know, for the inferior vena cava, it's at the level of T8. For the esophagus, it's at the level of T10. And the aorta is at the level of T12. So three major openings in the diaphragm. One for the inferior vena cava, T8. One for the esophagus, T10. And one for the abdominal aorta, that is T12. So the esophagus is actually passing here through the right crust of the diaphragm, one of the origins of the diaphragm. It forms like a sling around the esophagus, so whenever the diaphragm contracts, it will close the esophagus so that you don't have food going back. Okay, so that is the shortest part of the esophagus, which is basically the abdominal esophagus. It's about half an inch, yani 1.25 centimeters, and this is where it joins the stomach. Now this angle created by the esophagus joining the stomach is called the cardiac angle or the cardia. Okay? Now this is the lower esophageal sphincter. It's a sphincter that will prevent food from going back to the esophagus. But it is a physiological sphincter. If you feel it, you feel no muscle thickening because it is controlled physiologically by hormones, okay? And also up here we have the upper esophageal sphincter. That is basically where it is controlled by muscles. You can feel the muscles there, okay? Now, the esophagus along its way from where it begins to where it joins the stomach has four constrictions where the esophagus is really narrow at four locations. Why is this important? Because at these locations, what might happen?
Fatigue.
Huh? Trauma. Whenever you swallow something big or something that can, hurt. And foreign body, big stuff can get stuck in there. And whether you do accidentally, if you drink corrosives, kerosene or whatever, these are the areas that will be mostly affected. And these are the commonest sites of carcinoma, cancer of the esophagus. So what are these four sites? You know, how do they do a scope, right? Endoscopy. They will use a camera on a tube. They will insert the tube through the mouth. Okay, and then it will go through the esophagus all the way to the stomach, to the small intestine, to see if there is any abnormality. Or on that scope, you can tell the distance. The scope passes from the mouth all the way down. So passing the scope from the incisor teeth to the beginning of the esophagus, that is 15 centimeters. And at the beginning of the esophagus, the upper esophageal sphincter is constricted by a muscle, cricopharyngeus. Okay, that muscle will contribute to the upper esophageal sphincter, and that is where the esophagus is narrow, at the beginning of esophagus, below the cricoid cartilage, where the esophagus begins. the esophagus is narrow. Why? Because it is compressed by the cricopharyngeus muscle, part of the upper esophageal sphincter. That is about 15 centimeters from the incisor teeth. The second constriction is actually where the esophagus is crossed by the arch of the aorta. That is at the level of T4, and it is about 23 centimeters from the incisor teeth. Third site where the esophagus is narrow is actually where the esophagus is crossed by the left main bronchus that goes to the left lung. 25 centimeters, and it is at the level of T5. And the last site where esophagus is actually compressed is where it goes through the diaphragm. Okay? It's about 4 centimeters because the whole length of the esophagus is what?
40.
10 inches, 25 centimeters. Okay? So these are the 4 important sites where the esophagus is narrow. That's where you might have, foreign bodies get stuck in there, or that's the common site of trauma, whether by food, any foreign body that you might ingest, or by corrosive. And these are the common sites of cancer of the esophagus. Now, blood supply to the esophagus comes from 3 sources. One, this artery, it's called the inferior thyroid artery, which is a branch of thyrocervical trunk, which is a branch of subclavian artery. I mean, this block should have been after the cardiovascular block. But anyway, so that's one source. The other source is actually coming from the thoracic aorta itself. It's going to give us 2 or 3 esophageal arteries. And the third source for the abdominal part, this artery is called the left gastric artery. So I guess you're going to have to memorize them for now, but later you will know, it will be easier when you study the cardiovascular block to know where they are coming from. Whenever you are in doubt, if anyone asks you about the lymphatic drainage of any organ, and keep this in mind for now and forever. If you're in doubt, follow the arteries, follow the blood supply. Why do we care about lymphatic drainage of an organ? Huh? Yeah, cancers, infection can spread through the lymphatics to the lymph nodes associated with these organs. For example, the esophagus lower part is drained by the left gastric artery, so lymphatics will go to the lymph node along the origin of left gastric artery, which is on the aorta itself. Also, it is drained by branches from the aorta, so lymphatics will follow that and will go to lymph nodes around the aorta. We call them para-aortic lymph nodes, and so on. So whenever you're in doubt, you don't know where the lymphatic vessels, where do they drain, which lymph nodes, you follow the arteries. That will make your life easier instead of memorizing, lymphatic drainage of each individual organ or structure. Now again, when it comes to the venous drainage, I don't know whether this will make sense to you, but for now, again, memorize it. Upper part, inferior thyroid vein, they drain to brachiocephalic veins. You don't know what these are, or maybe you know. I don't know. You had an introductory lecture in the foundation block on the cardiovascular system. Did not cover that. Anyway, in the thorax we have 2 main venous systems, azygous, hemiazygous, one on the right, one on the left. Lower part, the abdominal part, will be drained. You know the difference between arteries and veins?
Yes.
In terms of function? So arteries will supply oxygenated blood. Veins will take the non-oxygenated, deoxygenated blood and take it back to the circulation. Okay? Now, for the gastrointestinal system, there is another venous system other than the venous system that we all know. It's called the portal circulation. Basically, the portal circulation, where you have digestion in the small and the large intestine and other organs that will contribute to digestion, they have their own venous drainage. Why their own venous drainage? Because you want the digested nutrients, vitamins, minerals, proteins to be taken to the liver. Liver is the largest factory in the body. It will process this material. This system of veins that will take digested nutrients from the gastrointestinal system to the liver, it's called the portal circulation. So portal circulation is a special venous system specific for the gastrointestinal system. It will take the nutrients digested in the gastrointestinal system to the liver. This is called the portal circulation. The rest of the venous drainage from the whole body will go to the inferior vena cava, or from the head and neck and upper limb will go to the superior vena cava. And then to the heart directly, okay? Now, do they communicate with each other? The portal system and this cable system? Yes. Why do they communicate with each other? Do they anastomose with each other? Yes. Why do they anastomose with each other? Why do you think God created anastomosis between arteries and veins and, arteries?
Exchange.
I mean veins and arteries. Why?
If something gets blocked,
Alternative way.
something gets blocked.
If you have main road and you close it for construction, what do?
Alternative way.
You find alternative ways. These are the anastomosis. So if the cable system is closed, blood will be diverted to the portal circulation. If the portal system is closed, blood will be diverted to the systemic circulation. Now these connections between the portal and systemic circulation are tiny, small, little veins that remain quiet and dormant unless one system is blocked. Suddenly blood is gushing through them and they will become enlarged. We call them varicose veins. In the body there are 4 sites where we have portal systemic circulation. One of these sites is the lower part of the esophagus. Why? Because lower part of the esophagus is drained by the left gastric, which goes to the portal, and is drained by the inferior phrenic, which goes to the inferior vena cava. So one of the sites where you have anastomosis between the caval system and the portal system is the lower part of the esophagus, because it is drained by 2 veins. One goes to the portal circulation and the other one goes to the inferior vena cava. Now, do they communicate with each other? Yes. By what? By smaller veins. When do they become enlarged and evident and might rupture?
Liver disease.
Whenever you have blockage in one of the system, for example, cancer in the liver, that we might block, the portal circulation, okay? And the patient will come to you actually vomiting blood, okay? It's called esophageal varices, and 50% of the patients will die because of that severe bleeding. Okay, nerve supply, whenever it comes to organs and viscera, it is always what? Autonomic nervous system. Organs, the heart, the lungs, smooth muscles, in general blood vessels, will be supplied by the autonomic nervous system. As opposed to what?
Muscles, skeletal muscles.
What is the other system you just finished? Somatic nervous system. Somatic nervous system, it's like skin. You will feel pain, touch, temperature, right? It goes to skeletal muscles in terms of motor activity, and in terms of sensory activity will bring sensation like pain, touch, temperature. Autonomic nervous system, on the other hand, will supply 3 structures: smooth muscles, glands, and
Cardiac.
cardiac muscle. When we say smooth muscles, what do we mean? Where do you find smooth muscles?
Internal organs. Around the whole
Around
GI.
hollow organs, like the GI.
The whole GI.
Blood vessels.
GI is smooth muscles. Bronchi are smooth muscles. Blood vessels are smooth muscles, right?
Any hollow organs.
Okay? So glands, smooth muscles, and
Cardiac muscles.
cardiac muscles, they are supplied by autonomic nervous system. Autonomic meaning sympathetic and parasympathetic. Sympathetic will prepare you to fight or flight, you flee. Okay? While the parasympathetic, you're sitting on the beach, chilling, drinking, having a good drink, and just enjoying life. That is the parasympathetic system in general.
حلال.
So whenever we... ايش سؤال كان؟
لا أهم شيء حلال.
مو بلازم Fine. So whenever we talk about blood nerve supply to any organ, I'm going to say it is supplied by sympathetic and parasympathetic. Sympathetic is coming from this, parasympathetic is coming from that. Most parasympathetic fibers will come from vagus. Okay? And you will study inshallah next year in the neuroblock more details about the autonomic nervous system. Now this is the esophagus. It's joining, what is that?
Stomach.
Stomach.
J-shaped structure, that is the
Stomach.
stomach. Now that is the cardiac notch, the angle between the esophagus and the stomach. The stomach has two curvatures, two borders, upper border which is the lesser curvature and the lower border which is the huge greater curvature. Okay? So the stomach has two borders, upper border, lesser curvature, and the greater border, the greater curvature. Now here, at the lower end of the lesser curvature, we have another notch. It's called the angular notch or incisura notch. Now if we draw a line here from the cardiac notch horizontally, and we draw a line here from the angular notch, between these two lines that will be the body of the stomach. Above this line is the fundus, and below that line is the pylorus. Okay? So the stomach is divided into three parts. The fundus, which is above this line. Fundus, if you take an X-ray, you cannot see organs, right? Can you see organs you cannot see soft tissue by X-rays. But you will see this part is filled with, will look dark, like dark clouds, because it is filled with air. You drink, you eat food, drink will go down and air will go up. So always the fundus is filled with air. And this is the body, and this is the pylorus, or the pyloric canal. So this would be the pylorus. Pylorus starts by antrum, entree, like entrance to the house. And then we have about an inch, that is the pyloric canal. And at the end here, we have the pyloric sphincter. And when you go to the lab, actually feel it. It is an actual anatomical sphincter, okay, caused by thickening of the smooth muscles. Now, what do we notice here? This is the mucous membrane of the stomach. What do you notice in this picture? It's called the rugae. The mucous membrane of the stomach is called the rugae. What do you notice here?
It's folded. And you mean the ridges? For surface area,
It is
ridges.
folded, right? Why do you fold the mucosa of the stomach? Increase the surface area so that for digestion and a little bit of absorption and
For expansion.
and the stomach will expand. If the mucous membrane is firmly adherent, is attached really well to the underlying muscles and is not folded, what's going to happen when the stomach expands? It will rupture, you will have ulcers. So that's why the mucosa is folded. Whenever the stomach expands, you will have mucosa that will remain intact, does not break. Okay? Now, okay. Now, the gastrointestinal system is similar to the cardiovascular system, to the heart, and similar to the lungs. How? It is covered by a serous membrane. The heart, we call that pericardium. The lungs, we call that pleura. Now, the serous membrane that covers
Abdomen.
the gastrointestinal system is called the peritoneum. And it's a simple concept. If the peritoneum is covering a wall, anterior abdominal wall, posterior, that is called the parietal. If the peritoneum is covering an organ, a viscera, that is called visceral. And between visceral and parietal, you will have a tiny little space. It's called the peritoneal cavity filled with peritoneal fluid. Simple. Okay? Now, the visceral peritoneum covering the stomach, the anterior surface of the stomach, and the posterior surface of the stomach. These two layers of peritoneum, they will meet at the lesser curvature, and they will go together from the lesser curvature to the stomach. This two-layer fold of the peritoneum is called the lesser omentum. Lesser omentum. Why did we call it lesser omentum?
Because there's a great
Because we have a greater omentum, okay? Now, similarly, these two layers of peritoneum covering the stomach will meet at the greater curvature, and they will go down like a towel, covering all the abdominal organs. It is called the greater omentum. The greater omentum. And it's like the policeman of the abdomen. I don't know who's giving you the lecture on the peritoneum, but they're going to talk about that. Whenever you have inflammation, whenever you have perforation, this greater omentum will go and try to seal it, to wrap it, so they don't have spread of the infection and you don't have bleeding and so on. Okay, so this is the lesser omentum. Two-layer fold of the peritoneum covering the stomach will meet here and will go from here to the liver. And this is the greater omentum. Again, two layers of the peritoneum covering the stomach will meet here and will go like a towel covering the abdominal organ. It's called the greater omentum. Now, this is a little bit thickened. It attaches the liver to the duodenum, which is the first part of the small intestine, and last part of the pylorus. It's called the hepatoduodenal ligament. Hepatoduodenal ligament. It is very important because if you open it, you're going to see three important structures in that. Now, remember this, for the whole gastrointestinal system, you will have two layers of muscles. You will have two layers of muscles for the whole gastrointestinal system. Outer longitudinal muscle and the inner. Outer longitudinal muscle will act like a spring. You know what a spring is?
Yeah.
Huh? Will push food like this down.
Okay.
The inner circular muscle will contribute to what? Peristalsis. Contraction, relaxation, and so on. Okay? Now the stomach is an exception. It has an additional layer. The innermost oblique layer. But the oblique layer is an incomplete layer. Longitudinal is complete. Inner circular is complete. What about the oblique, the additional layer? It's basically concentrated around the fundus, and we have few fibers that spread over the body. It's called the oblique layer. And it's only in the stomach. Otherwise, the whole gastrointestinal system has two layers, outer longitudinal
Inner circle.
and inner circle.
Doctor,
Now,
what does those fibers do?
yeah,
The
same
third
question.
layer.
They will help with the contraction digestion.
Mixing.
Muscles, right? And here an example, sometimes you have thickening of the inner circular muscle at the pyloric sphincter. You know, a newborn baby might be born with a really thick muscle. So milk cannot go from the stomach to the small intestine. Baby will come to you vomiting, milk all the time. They need to go with surgery and,
Cut.
ease that constriction, okay?
Can you just explain why is oblique layer not big all the time?
I did not explain it.
Yeah.
I said, only in the stomach you will have an additional layer. The oblique muscle fibers. And this oblique muscle fibers, this layer of muscle is different from the longitudinal and the inner circular in a fact that it is an incomplete, dispersed fibers, does not cover the whole stomach completely as the longitudinal and the inner circular. And it's only present in the stomach.